If you snore, wake with headaches, or someone has seen you stop breathing at night, pay attention to what happens when you sleep on your back. Back sleeping doesn't cause a stroke by itself. But a 2023 review in Sleep Medicine Reviews notes that, in positional obstructive sleep apnea, breathing events can occur at least twice as often on the back as off it. Sleep apnea is associated with cardiovascular disease and stroke. The useful question is whether your sleep position is exposing a breathing disorder you haven't been tested for. The position is easy to blame. You fall asleep face up, hear that it may be dangerous, and the obvious response is to force yourself onto one side tonight. But that skips the part that needs attention, whether your airway is repeatedly narrowing or closing while you sleep. Obstructive sleep apnea, or OSA, is a condition in which the upper airway repeatedly narrows or closes during sleep. When airflow drops enough, oxygen can fall and the brain can trigger a brief arousal that helps reopen the airway. You may not remember those arousals in the morning. For some people with OSA, body position changes how often those breathing events happen. A commonly used definition of positional OSA is that respiratory events occur at least twice as often while someone is on the back as they do in non-supine positions. The definition describes how breathing event frequency changes with position. By itself, it can't tell you whether a back sleeper has OSA or whether side sleeping would be sufficient treatment. Gravity and body position can change how an already vulnerable airway behaves. Imagine two people who both wake up on their backs. The first person breathes normally, wakes rested, has no witnessed pauses in breathing, and has never had a reason to suspect sleep apnea. Finding that person on the back in the morning is not evidence that something dangerous happened overnight. The second person snores loudly, sometimes wakes gasping, feels unrefreshed after a full night in bed, and has a partner who has noticed pauses in breathing. If those symptoms become worse while that person is lying face up, the sleeping position is no longer the whole story. It may be revealing a breathing disorder that deserves evaluation. The rule never back sleep after 60 is too simple to be useful. Older age is an established risk factor for OSA, but the real questions are whether the airway is obstructing during sleep, how often it happens, and whether position changes it. A sleep evaluation can measure those breathing events instead of asking you to guess. It can show how often airflow is reduced or interrupted, how oxygen changes during the night, and whether the pattern becomes worse when you roll onto your back. Why can the same airway behave reasonably well on one side and become less stable on the back? The answer starts with gravity, the tongue and soft palate, lung volume, and the amount of space available for air to move. When you are awake, keeping your airway open is usually effortless. Muscles around the tongue and throat remain active. You change position without thinking about it, and your breathing adjusts from one moment to the next. As you move into sleep, the muscles that help stabilize the upper airway relax. That happens to everyone. In a person with plenty of space in the throat, it may cause no meaningful problem at all. But if the airway is already narrow or unusually collapsible, that normal reduction in muscle activity can make obstruction more likely. When you lie face up, gravity shifts soft tissues toward the back of the throat. The tongue is part of the picture, but it isn't the whole explanation. The 2023 Sleep Medicine Reviews paper reports that obstruction occurs more commonly while supine, particularly around the soft palate and epiglottis. The popular explanation that the tongue just falls backward leaves out how flexible the upper airway is. Its stability depends on anatomy, muscle activity, breathing pressure, lung volume, and other traits that differ from one person to another. In someone who is susceptible to sleep apnea, lying on the back can shift enough of those factors in the wrong direction at the same time. Position can amplify an existing airway vulnerability. The sleeping posture doesn't create the underlying anatomy, and diagnosis still depends on confirming OSA and measuring its severity. A vulnerable airway can simply become more obvious under one set of mechanical conditions. Sleep stage can complicate the picture as well. Breathing may behave differently in rapid eye movement sleep than in other stages, and a person doesn't spend equal amounts of every sleep stage in every body position. That is one reason a clinician looks at the whole recording rather than treating one stretch of snoring on the back as a complete diagnosis. The same review reports greater airway collapsibility while supine than while lying laterally. A 2013 Sleep Medicine Reviews review also points to reduced lung volume and less favorable airway geometry as contributors to this positional pattern. Supine posture can also reduce lung volume. That matters because lung expansion creates mechanical tension that helps stabilize the airway above it, so losing some of that volume can make a vulnerable airway easier to narrow. Think about gently stretching a flexible tube lengthwise. The extra tension can help keep the tube more open. Reduce that pull, and a vulnerable tube can become easier to narrow. The human airway is obviously more complicated than a tube, but the principle helps explain why lower lung volume while face up may contribute to airway instability. For some sleepers, rolling onto the back changes very little. For others, the same move can turn relatively stable breathing into repeated obstruction through the night. A sleep study can capture that difference in the same person. Their anatomy has not changed during the night. What changes is how that anatomy behaves under a different set of mechanical conditions. OSA also becomes more common with age. Being over 60 doesn't mean your airway automatically collapses when you're face up. Age sits alongside anatomy, weight, sex, muscle function, and other individual characteristics. Two people of the same age can therefore have completely different responses to the same sleeping position. Someone may appear to sleep normally for part of the night, then begin snoring much more loudly after rolling face up. A partner may notice pauses in breathing that seem to appear mainly in that position. Later, the sleeper rolls onto one side, and the breathing sounds different again. That pattern can't diagnose sleep apnea by itself, but it is useful information. It tells you that position may be changing what happens inside the airway. Once the airway closes, snoring is no longer the main concern. Airflow falls or stops, oxygen can drop, carbon dioxide can rise, and the sleeping brain has to respond. The response may be a brief arousal that restores enough muscle activity to reopen the airway. That rescue can happen repeatedly without the sleeper remembering it the next morning. The cardiovascular concern comes from repeated obstruction and the responses it triggers during those hours. Picture an obstructive event. The chest and diaphragm may still be trying to breathe, but the narrowed airway is limiting airflow. As the obstruction continues, oxygen can fall, carbon dioxide can rise, and the brain can trigger a brief arousal. That arousal increases the drive to breathe and helps restore airway muscle activity. The airway opens, airflow returns, and sleep resumes. In significant OSA, the cycle can repeat throughout the night. The American Heart Association describes OSA as recurrent upper airway obstruction that can produce intermittent hypoxemia, autonomic fluctuation, and sleep fragmentation. Those repeated cycles create both immediate and longer-term physiological stress. When breathing is interrupted and oxygen falls, protective systems become more active. Heart rate and blood pressure can fluctuate as the body responds to the obstruction and to the reopening of the airway. The cardiovascular statement also discusses sympathetic activation, blood pressure changes, inflammation, metabolic effects, and other pathways that may connect OSA with cardiovascular disease. One event may be brief, but OSA is a repetitive disorder. Breathing becomes unstable, the body responds, airflow returns, sleep resumes, and another event may follow. The reason those repeated arousals matter is that they fragment sleep even when the person doesn't remember waking. Someone can spend a normal amount of time in bed and still have sleep that is repeatedly interrupted by the body's effort to restore airflow. That helps explain why nighttime breathing problems can show up the next day as sleepiness, fatigue, or trouble concentrating instead of as a memory of being awake. The scientific statement focuses on repeated exposure to intermittent hypoxemia, autonomic activation, and other stresses in a disorder that may continue night after night. It does not treat one oxygen dip or one pillow position as a direct predictor of stroke. Snoring alone doesn't establish stroke risk, and one night of back sleeping isn't equivalent to years of untreated OSA. The evidence we can use here concerns the breathing disorder, its severity, and the stresses created by repeated obstruction. The Sleep Heart Health Study gives us a useful example. Researchers followed 5,422 adults who had no previous stroke at baseline and were not being treated for sleep apnea. Their breathing was measured with polysomnography, and the median follow-up was 8.7 years. During follow-up, 193 ischemic strokes occurred. The result was more nuanced than a single risk multiplier. Among men, increasing OSA severity was associated with greater ischemic stroke risk. In women, the same statistically significant trend across apnea-hypopnea quartiles was not seen, although risk appeared higher at more severe levels of OSA. The study did not use back sleeping as the exposure, so it cannot supply a universal stroke risk multiplier for sleep position. The sex differences in the results are another reason to avoid applying one number to every viewer. It's also an observational study, which matters when we talk about causation. Researchers measured OSA, then observed who developed stroke over time while adjusting for other risk factors. That kind of design can show an important association, but it can't prove that changing sleep position would remove the observed stroke risk. The study supports taking OSA seriously without turning back sleeping into a standalone stroke diagnosis. The sex difference in the results is useful for another reason. It reminds us that OS risk isn't a one-size-fits-all number. Severity, age, cardiovascular health, sex, and other characteristics affect how research findings apply to an individual. That is exactly why a measured sleep disorder is a better target for medical decisions than a universal rule about which side of the body touches the mattress. The study supports a more careful chain. OSA can repeatedly interrupt breathing. Those interruptions can produce intermittent low oxygen and cardiovascular stress. Epidemiological evidence links OSA with stroke risk. In someone whose OSA becomes substantially worse while face-up, body position can influence how much sleep-disordered breathing occurs during the night. That leads to the practical question. How would you know whether these breathing interruptions are happening to you? You can't answer it by checking which side of the pillow your head is on when you wake. Some clues appear at night, some show up during the day, and sometimes the person sleeping beside you sees the problem first. Sleep apnea is easy to miss because the person experiencing it may be the last person to notice. You are asleep when the airway closes. You usually don't remember the brief arousals that reopen it. So some of the clearest clues come from what happens around sleep, rather than from anything you consciously feel during an episode. Loud, frequent snoring is one clue, but snoring alone doesn't diagnose OSA. Snoring happens when tissues in the upper airway vibrate as air moves past them. Plenty of people snore without having OSA, so snoring by itself isn't enough. It becomes more informative when it appears with witnessed pauses, gasping, choking, or excessive daytime sleepiness. A witnessed pause in breathing is more concerning when it repeats. A spouse or partner may notice that the snoring suddenly stops. There is a period of silence. Then breathing resumes, sometimes with a gasp, choking sound, or abrupt snort. The sleeper may remember none of this. If someone repeatedly notices pauses in your breathing while you're asleep, bring that observation to a healthcare professional instead of assuming it is ordinary snoring. Waking up gasping for air deserves the same attention, especially when it occurs with loud snoring or repeated breathing interruptions. Daytime sleepiness is another clue. You may spend enough time in bed and still struggle to stay alert during quiet parts of the day. Some people notice fatigue, trouble concentrating, or a sense that sleep was never restorative. Morning headache and dry mouth can occur too, although both have many possible causes. No single symptom proves OSA. The pattern becomes more useful when several signs appear together. Loud habitual snoring plus witnessed breathing pauses tells you more than snoring alone. Add repeated gasping or daytime sleepiness, and there is more reason to ask whether sleep-disordered breathing needs to be evaluated. The National Heart, Lung, and Blood Institute list breathing that starts and stops, frequent loud snoring, and gasping among the nighttime symptoms of sleep apnea. It also lists daytime sleepiness or tiredness, dry mouth, and headache among symptoms people may notice themselves. The Institute also notes that you may not know about the nighttime signs until someone else tells you. That makes a partner's observation more valuable than it may sound. A report such as your breathing pauses before a gasp is different from you toss and turn. The first describes a breathing pattern a clinician can investigate. The second may be real, but it is much less specific. Difficult blood pressure control has many possible causes. The American Heart Association still recommends OSA screening in people with resistant or poorly controlled high blood pressure, which makes sleep-disordered breathing worth considering in that clinical setting.
As you can see here,
suppose your partner says the loud snoring and breathing pauses become much more noticeable when you roll onto your back than improve when you turn onto your side. That observation can't tell you how severe the problem is or what treatment you need. But it gives a clinician something specific to investigate. If you already use a sleep tracker or another consumer device, treat its data as preliminary information. The American Academy of Sleep Medicine says OSA diagnosis and treatment decisions require medical evaluation and shouldn't rest on automatically scored home test data alone. If you find this kind of evidence-based health explanation useful, you can subscribe and keep watching. Look for a pattern rather than one isolated symptom. Frequent loud snoring, repeated pauses in breathing, gasping during sleep, daytime sleepiness, or a partner who sees something you can't see yourself are all worth bringing into the same conversation. But if several of these signs do sound familiar, changing your sleeping position tonight may change the symptoms without answering the larger question. They roll onto their side, the snoring improves, and they assume the problem has been solved. Sometimes positional therapy really can help. But whether changing position is enough depends on the type and severity of sleep apnea and on what happens to your breathing away from the back. A 2019 Cochrane review examined randomized trials of positional therapy. The methods included vibration alarms and physical supports designed to reduce time spent sleeping face up. The review included 8 studies with 323 participants. Compared with inactive control, positional therapy improved the apnea-hypopnea index and sleepiness in the available trials. But when positional therapy was compared with CPAP produced a greater reduction in that breathing event index. For selected positional OSA, side sleeping can help. Whether it is enough has to be demonstrated by the person's symptoms, breathing measurements, and follow-up. Picture 2 sleep studies. In one, breathing events become uncommon away from the back. In another, they improve on the side but remain frequent. Both people may benefit from avoiding the face-up position, but the second person still has substantial sleep-disordered breathing outside it. Quieter snoring alone can't be the measure of success. The Cochrane review also noted that the available studies were short. It couldn't establish the long-term effects of positional therapy, including long-term cardiovascular outcomes. That uncertainty matters because the concern is stroke. If OSA is the disorder connected with cardiovascular and cerebrovascular risk, the goal is to control the breathing disorder rather than merely make snoring quieter. For some people, positional therapy may be part of the plan. The same cardiovascular statement also discusses CPAP, oral appliances for selected patients, behavioral changes, and weight management when appropriate. Which option fits depends on the diagnosis and severity. Position-based treatment has a practical limitation too, because you are asleep. You may start on your side and later roll onto your back without knowing it, which is why newer approaches can use vibration or other feedback to prompt a position change. Even when a device keeps you off your back, follow-up testing may still be needed to show whether treatment is working. The AHA statement recommends follow-up sleep testing to assess treatment effectiveness. This matters even more if you already have a diagnosis and prescribed treatment. If you use CPAP, an oral appliance, or another treatment recommended by your clinician, don't stop because you snore less on your side. A quieter bedroom doesn't establish that your breathing has normalized. If you've never been evaluated but several warning signs sound familiar, you don't need to spend tonight terrified of rolling face up. Notice the pattern, ask the person who sleeps beside you what they've seen, and bring that information into an evaluation. Once you know whether OSA is present, its severity, and how much position changes it, the question becomes much easier. What does my breathing actually do during sleep? So what should you do tonight? Start by separating occasional back sleeping from back sleeping that comes with repeated signs of sleep-disordered breathing. If you sometimes wake face up but don't have loud habitual snoring, witnessed breathing pauses, repeated gasping, unexplained daytime sleepiness, or another reason to suspect OSA, that position alone isn't evidence that your oxygen dropped or that you were having apneas. The situation changes when several warning signs are present. Maybe your partner says your snoring becomes much louder when you're face up, has noticed a pause in your breathing followed by a gasp, or notices that the pattern improves when you roll onto your side. Those details are useful because they tell a clinician what to investigate. Write down what was actually observed, such as repeated pauses, gasping, choking sounds, or a clear change with position. A short note is more useful at an appointment than a vague memory from weeks earlier. If side sleeping feels comfortable, choosing that position while you arrange an evaluation is reasonable. In genuinely positional OSA, avoiding the back can reduce breathing events, but that change doesn't prove the underlying disorder has disappeared. If you already have diagnosed OSA, keep using the treatment your clinician prescribed unless that clinician changes the plan. CPAP provides pressure that helps keep the airway open. A change in sleeping position can sometimes complement treatment, but it shouldn't replace prescribed therapy on your own. Don't use snoring volume as your only measure of success. The relevant questions are what happens to airflow, breathing events, oxygen, symptoms, and overall control of the disorder. Consumer wearables can help you notice patterns. OSA diagnosis still requires medical evaluation, and the American Academy of Sleep Medicine says a medical provider should determine when a home sleep apnea test is appropriate and interpret the result in clinical context. If a watch reports an unusual oxygen pattern, save the information and discuss it, rather than trying to diagnose yourself from one graph. A consumer device may help you notice that something repeats at night, but medical testing is designed to answer a different question. Does the pattern meet diagnostic criteria, and should it change care? When you talk with a clinician, use the plain observations. Say that someone has seen you stop breathing, that you wake up gasping, that you struggle to stay awake during the day, or that your snoring changes dramatically with position. You don't need to diagnose yourself first. You are giving the clinician the clues needed to decide whether testing makes sense. The goal tonight isn't to build a barricade of pillows because you're afraid of rolling over. Keep using prescribed treatment. Notice whether several OSA clues are present, and pay attention to whether they change with position. The next decision should come from measured breathing, rather than from guessing based on the position you wake up in. A sleep evaluation replaces suspicion with measurements. Instead of asking whether you snore too loudly or happen to wake face up, testing can record how you breathe through the night. Polysomnography is the standard diagnostic test when OSA is suspected after a comprehensive sleep evaluation. In a sleep center, sensors can record brain waves, heart rate, airflow, breathing effort, oxygen levels, muscle activity, and other signals across the night. Body position can be recorded too, which lets clinicians compare respiratory events during supine and non-supine sleep when enough time is captured in each position. If events occur mainly while face up, position may become an important part of treatment. If they remain frequent in other positions, avoiding the back is less likely to be enough by itself. Testing also adds context that a partner can't provide. A partner may see breathing stop, while the study can quantify the overall pattern and help determine severity. A full laboratory study can also tell whether breathing disturbances cluster in a particular sleep stage or position. That context matters because a raw event count without knowing when the events occurred can hide why the night looked bad. For a positional question, the clinician wants enough information to see whether the difference between face-up and other sleep is real and clinically meaningful. Clinicians don't interpret a sleep study from one score alone. They read the event index alongside oxygen, respiratory effort, sleep stage, symptoms, and the rest of the clinical picture. That context lets them evaluate a report such as "my partner says I snore worse on my back," instead of treating the observation as a diagnosis. Home sleep apnea testing is a medically ordered option for selected adults. ASM guidance allows a medically ordered home sleep apnea test for uncomplicated adults whose signs and symptoms indicate an increased risk of moderate to severe OSA. Home testing records fewer signals than full polysomnography, and its limits matter. The ASM recommends polysomnography when a home test is negative, inconclusive, or technically inadequate, but OSA is still suspected. The same guideline recommends polysomnography rather than home testing in several complicated situations, including significant cardiorespiratory disease and a history of stroke. Once testing answers whether OSA is present, its severity, whether it worsens while face up, and whether treatment is controlling it, the sleeping position question becomes much simpler. If the pattern is strongly positional, avoiding the back may become part of the plan. If important breathing disturbances continue on the side, position alone is unlikely to be enough. And if an appropriate medical evaluation doesn't find OSA, you've avoided turning a frightening headline into a nightly source of anxiety. Evidence linking back sleeping directly to stroke in every adult over 60 is lacking. The evidence-backed concern is OSA, which can worsen in the supine posture in susceptible people and is associated with cardiovascular disease and stroke. So if you remember one question tonight, remember this one. Does my breathing change when I'm face up? If you have no warning signs, waking face up isn't a reason to panic. If you snore loudly, wake gasping, have witnessed breathing pauses, or recognize several of the other clues we discussed, body position may be giving you useful information worth taking to a clinician. Once your overnight breathing has been measured, you no longer have to guess from the position you wake up in.